Dr. Amit Agarwal, you could put your video on.
I'm there. I'm working behind the scene using my phone, doing part rounds. So I was escaping the whole discussion, hearing everything.
Okay.
Very good morning, everyone. Welcome to Indian Society of Gastroenterology Masterclass. This is the 29th Masterclass in series. And as you are aware, that for last 4 weeks, we are covering gastrointestinal cancers. We had masterclasses on cholangiocarcinoma, carcinoma gallbladder, and last one was carcinoma pancreas, which was done so masterly last week. So in the same series now we move on to one more important gastrointestinal luminal cancer, that is carcinoma esophagus. And we all know that carcinoma esophagus is such an important disease to all of us, all gastroenterologists, that we will find patients with carcinoma esophagus coming to us almost every other day. So we thought that we have a one panel discussion on carcinoma gallbladder, and for this panel we have a very eminent moderators and panelists. So it's my pleasure to introduce to you the moderator for today, Dr. Bhaskar Nandi. Dr. Bhaskar Nandi is chairman and head of department of gastrointestinal sciences at Sorvada Institute of Sorvada Hospital and Research Institute in Faridabad, and Dr. Bhaskar Nandi had been the head of department of research and referral center in the Army Hospital, and he is a transplant hepatologist, which is his specialty. Welcome, Dr. Nandi, for joining in for this masterclass.
Thank you, sir.
And for the panel, we have Dr. Amit Meodev. Amit Meodev, I think all of us, this name is very familiar to all the GI, and he is in Mumbai, and he's one of the person who teaches endoscopy so well. He runs many courses on GI endoscopy, and he's a true master and teaches endoscopy so well. Welcome, Dr. Amit Meodev, to this masterclass.
Yep.
We have Dr. C.S. Pramesh. C.S. Pramesh is a surgical oncologist. He's also the director of Tata Medical Center, one of the iconic center of cancers in our country, and he heads that institute. Dr. Pramesh, welcome to this masterclass. Dr. B.K. Mohanty. B.K. Mohanty is a radiation oncologist. He had been at All India Institute of Medical Sciences almost all his life, and then he worked for a couple of years in Fortis Hospital in Gurgaon. Now he has moved to Bhubaneswar, and he's the director of Kalinga Cancer Institute at Bhubaneswar. Welcome, Dr. Mohanty. Dr. Amit Agarwal, he is a medical oncologist, and he is at BLK hospitals in Delhi. Welcome, Dr. Agarwal. And we have Dr. Saugata Sen, who is a radiologist, and he is at Tata Medical Center in Kolkata. So welcome the moderator and the panelist, and also let me welcome Dr. Saraswat, Dr. Vivek Saraswat, who is head of gastroenterology at SGPJ Lucknow, and he's also the president of Indian Society of Gastroenterology. With this, welcome all the panelists and the moderator. Welcome all the viewers, and we will start the discussion. But before that, let me request Dr. Saraswat to speak to you for a couple of minutes. Yes, Saraswat.
Thank you, Govind. Good morning to all the panel, the moderator, the panelists, and our participants and viewers. It's a great pleasure to have you back on this weekly ISG Masterclass. As Dr. Govind has told you, this is the fifth in our series after GI lymphoma and then the 3 biliopancreatic malignancies. Now we are dealing with the two or three common luminal malignancies. As we've discussed after the initial phase when we had lectures given by very eminent speakers on important topics in gastroenterology and hepatology, we have moved to this panel discussion mode in which problems that need a multidisciplinary, multi-speciality handling are being highlighted. All of us but in this day and age, it is really very difficult to keep pace with developments happening in related or sister specialities like surgical colleagues, the radiation and medical oncology colleagues, our imaging colleagues. And especially in the setting of GI malignancies, where the need of the hour is to have a close team and integrated team approach, it is important to have sessions where inputs are obtained from all the specialists and they are discussed. So we hope that you've been enjoying the series of in GI oncology from the ISG. And as mentioned, esophageal cancer is one of the common and important malignancies that we frequently encounter. Approaches to this vary from center to center, and organized, systematic, multi-speciality approaches are the rarity rather than the rule as they ought to be. So we hope that all of you will enjoy and learn from this particular panel discussion. With this, I'll request Dr. Bhaskar Nandi to set the ball rolling to introduce the topic and start the panel discussion. Dr. Bhaskar.
Thank you, Dr. Saraswat and Dr. Govind, for the kind introduction of the panel. Good afternoon to the viewers. Today we discuss cancer of the esophagus in our ongoing masterclass series on GI cancers. We all agree that a gastroenterologist is the first point of contact for a patient with esophageal cancer, because when he presents with dysphagia, I think he presents to the gastroenterologist for an endoscopy. Unfortunately, our next point of contact is only when we are considering this patient for esophageal stenting. And there is a growing realization among all gastroenterologists that management of esophageal cancer is much, much more than just the initial biopsy and the final stenting which we are doing. There are multiple therapeutic modalities now available, and the challenge today is to identify the subgroup of patients and direct them towards the correct specialty for this multimodal approach. In fact, I think cancer of the esophagus, you'll agree, is the best example of a disease that requires a team and a multidisciplinary approach rather than a single specialist like gastroenterologist treating it. We felt there is a gap in this knowledge, how to manage and strategize in such cases. So the purpose of our panel discussion today exactly will be to address this issue and to provide guidance and a very lucid clinical approach to such patients. And we are indeed privileged to have a very, very reputed panel who have been introduced to you by Dr. Saraswat and Dr. Govind. So on the behalf of the panel, I thank Dr. Govind, Dr. Saraswat, and the ISG for giving us this platform. And I think we start our discussion on this. I'll just share the screen. May I do that, sir?
Yeah, please.
It's visible. The screen, I think, is right.
Yes, please.
To recapitulate, we all know that esophageal cancer is the commonest GI cancer that we see in our country. It's the fourth most common cancer in India. If we look at the incidence, it's around 4.7 to 6.4, and which translates to over 40,000 new cases a year for esophageal cancer in our country. The geographic distribution is uneven. It's highly prevalent in the northeastern states, which actually form part of the esophageal cancer belt, which extends from northeast China to the Middle East and comes to northeastern states in our country. The Kashmir Valley also has got a very high incidence. What we have seen is the patients with esophageal cancer, they present late, and by the time they present to us, over half of them are actually beyond any definitive treatment. So this definitely requires, we need to address this and increase awareness that the patient comes to us quite early. Histologically, in our country, squamous cell carcinoma is the commonest, but then if we look at the world epidemiology of esophageal cancer, countries with a high human development index have got increasing incidence of adenocarcinoma at the GE junction rather than squamous cell carcinoma. And I think the trend has already started, and in our country too, in the coming years, I think we'll have more and more cases of adenocarcinoma. But right now, squamous cell carcinoma predominates. These are the usual risk factors which we are all aware about. For squamous cell, basically it is achalasia, smoking, a lot of environmental factors, and of course genetics has got a role to play in this. And for adenocarcinoma, it is obesity, smoking, and a Barrett's esophagus, which we'll discuss in a little bit more detail. So with this introduction, I think we start our discussion, and I'll first request Dr. Amit Medeo, sir, that the patient first presents to the gastroenterologist with dysphagia. We do a biopsy, we do an endoscopy. And when you do an endoscopy, if you see a growth, what exactly goes through your mind? Like, how do we assess this growth in terms of its location, its extent, and how do we proceed to take the biopsy? Do the number of biopsies have got any relevance to this?
Yeah, thank you, Dr. Nandi. And now let me go to my first slide. So I think it's very, very important that when the patient comes to an endoscopist or a gastroenterologist and of dysphagia, and you find a growth in the esophagus. So now what does that endoscopist actually do? So it's very important what you see and how you report. Because the things that you are going to mention into the report are going to play a very important role, not only from a surgeon's perspective, but even from any new adjuvant therapy like chemo or radiation. First and foremost, we have to assess the extent of the growth. So as all of you know, as endoscopists, when we measure anything in the esophagus, we measure it from the incisors. So the extent, so we begin is how many centimeters from the incisors is the growth actually located. So if you were to see the anatomy of the esophagus as described in this chart, you see here, when the growth is anywhere between 15 to 20 centimeters from the incisors, you have to say that this growth is in the cervical esophagus. Anywhere between 20 to 30 is the thoracic esophagus, the upper and the middle. So 20 to 25 is upper thoracic, 25 to 30 is middle thoracic, and you see here 30 to 40 is the lower thoracic esophagus. Now, in Indians, of course, this normally this esophagogastric junction, which is supposed to be at 40, can even be at 35. So this length can vary a little bit because of the short stature, short height. But this is the general broad lengths of from the extent from the incisors, which the endoscopist has to describe. Now, how long is the growth? So many times it may happen that you may not be able to pass the growth. You may find a lesion which is completely blocking the esophagus. Now, ideally, you should try to bypass or go beyond the growth and try to give the further therapist an indication as to how long the growth is. Because in general, it is thought that growths which extend for more than 7 centimeters in length are usually inoperable. However, that inoperability is checked by many other factors, but this length is very important. It's not just a radiological finding, because sometimes on radiology, you may not exactly see. Whereas on endoscopy, the proliferative part may be in only 5 centimeters, but you may find a creeping submucosal growth coming up as well as down. And total length may not be 5, but it may be 8. So now I just want to show you, in addition to the extent, you have to tell what is the type of the growth, whether the growth is a proliferative growth, whether it is a stricturous lesion, or whether it is the combination of ulceroproliferative, ulcerostricturous. Now, what is the importance of this? The reason is such type of proliferative growths, they respond beautifully to radiotherapy, for example. They dissolve with radiotherapy. But the same radiation, if you give for a growth, which you see on the right side upper picture, which is a stricturous creeping lesion, now after radiation, such type of growth will be associated very likely with either stenosis, or it may be associated with even a tracheoesophageal fistula. So therefore, the type of growth that you see is important. Now the picture on the lower part, on the left side, in the quadrant, you see these creeping islands. You see this submucosal growth, which is spreading. The actual growth is below. But you see here in the submucosa, these whitish areas. So these whitish areas are submucosal spread of the tumor. So this is going up slowly. So therefore, even this extent has to be measured on endoscopy. So what the endoscopist has to do is, number one, tell from where the growth starts, from where the growth ends. So that is the length of the lesion, and also the type of lesion is very important. Next, of course, is biopsy. Now, if you can't bypass it, if you can't pass the growth, we can do a simple dilatation. Now we have endoscopes available which are of thin diameter also. So you do a balloon dilation of the growth. You need not do a very large dilatation. Even if you dilate up to 12 mm, you will be able to gently pass the scope through the lesion and thereby give a proper length measurement to the further therapist. So we go to the next slide now. So next slide is especially when you come to lower esophageal lesions and growths at the esophagogastric junction, you have to follow this Sievert's classification. So as an endoscopist, we have to say whether the growth is above the esophagogastric junction, whether it is at the esophagogastric junction, or whether it is below the EGJ. So the below the EGJ growths are actually type 3 Sievert, which are actually classified as gastric cancers. So even if it starts at the EGJ, but predominantly the growth is in the beyond the EGJ, that means this should be classified more as a gastric cancer. And in general, if you go to see the overall results of any treatment, these patients do not respond very well. So type 3 growths are the people who fare worstly with any sort of treatment as compared to type 1 and type 2. So when you have the lower esophageal growths, you have to say, or you have to mention in your report what type of Sievert classification this growth is falling into, type 1, type 2, or type 3. So this chart clearly tells you what is type 1. Okay, so this is approached predominantly as an esophageal cancer. And type 2, it can be approached either esophageal or EGJ cancer. So it can be a squamous or adenocarcinoma, whereas type 3 is invariably adenocarcinomas. Then we go to the third slide. And if you go to the third slide, when you're taking a biopsy, from where do we take this biopsy? See, it should not just take biopsy blindly. Now look at this growth. This growth is stricture. It is also proliferative. It is also ulcerated. Now in such type of growth, you should never take a biopsy from the area where you see slough. If you see the whitish slough, don't take the biopsy from there. Ideally, you should take the biopsy from this proliferative area and the normal area. So try to go to the junction of these two areas and try to take a chunk. But if you take a biopsy from the area which is sloughed out, invariably your biopsy is going to be negative. What happens if you can't pass the growth and you can't actually see the growth? It is a stricturous lesion. You should try to dilate it a little bit. And very rarely, if dilatation is also not possible, you can even take a simple brush cytology by putting in a normal endoscope cleaning brush. See, for esophageal lesions, you don't have to use a small brush. You can use an endoscope cleaning brush and rub that brush inside the stricturous portion. And that brush itself, you can move it on a slide and you'll get excellent cells for cytopathology. So what type of biopsy forceps? Various types of biopsy forceps are used, but for growths, you should always try to use a spiked biopsy forceps. You see here down, I've shown you two biopsy forceps. One is a non-spiked and second is a spiked biopsy forceps. So for a lesion of this nature, if you want a perfect sample through your endoscopic biopsy, try to use a spiked biopsy forceps. In case you are not getting good chunks, you should use a biopsy forceps which has got serrated edges on the cups. In addition to that, nowadays, we also have jumbo biopsy forceps available, whereby you can take bigger chunks of the lesion. And if you find that the mucosa is appearing normal, but there is a growth there below, predominantly submucosal, you take a biopsy of the mucosa and then you do what we call as a well biopsy. So at the same place, you keep on digging. So take the biopsy at the same location multiple times. But in general, if you go to see, on average, it is advised that you should take at least 8 biopsies, and that too from a proper location if you want high positivity while achieving a diagnosis of the esophageal cancer. So that's what I will say as far as assessing a growth in the esophagus. Any question on that, Dr. Nandi?
Yeah, I think you have answered it very well. These are the common queries which every gastroenterologist has. And the important points you've told is, yes, it is important to actually go beyond and see up to what the lesion extends. So dilatation, if possible, is very much in order. And of course, the number of biopsies and which biopsy forceps to use. We move on to the next question. It is again for you. Barrett's esophagus is a risk factor for adeno-CA, and there is an increasing incidence of adenocarcinoma in our country now. Do you think we in India we underdiagnose Barrett's, or it's low, or how will you compare it to the West?
Well, initially speaking, for example, now over the last 30 years, I've been seeing that initially for the past 15, 20 years, at least in the beginning, when we used to perform endoscopies, we never used to see so much of Barrett's esophagus.
Exactly.
But nowadays we are seeing more and more patients of Barrett's esophagus. Now, whether Barrett's esophagus is genuinely related to GERD or no, or whether there's an independent factor which causes Barrett's esophagus, still we do not know. It's still not very clear. However, it is thought that Barrett's esophagus usually happens in those patients who have got long-standing gastroesophageal reflux disease. Now, how do we identify Barrett's esophagus? We'll go to the next slide. See, identification of Barrett's esophagus is very clear. For example, above I am showing you on the right side how a normal Z line looks. See, normal Z line, what is the meaning of Z line? Z line is the junction of the columnar and the squamous epithelium at the esophagogastric junction. So the columnar epithelium is basically gastric mucosa, whereas the whitish epithelium, what you see here, is the squamous epithelium, that is the esophageal mucosa. Now, if you find this pinkish mucosa, that is the gastric epithelium, creeping slowly onto this whitish epithelium, that is a Barrett's. That is likelihood of a Barrett's. Now, when you see such type of creeping, you see here, I've shown you classic examples on the right side. At various degrees of amount of gastric epithelium is creeping onto the squamous epithelium. Now, what is the meaning here? If you take a biopsy from that pinkish epithelium which is creeping on the whitish area, you will find intestinal metaplasia. Now, the issue is just intestinal metaplasia. If it is like that, one need not worry. But if that slowly gets converted to dysplasia, initially low-grade dysplasia, and then into high-grade dysplasia, then there is a possibility that it can get converted to esophageal cancer. So now, how do we report a Barrett's esophagus? We follow what is called as the Prague classification. So what I've shown you in this chart is the Prague classification of identification and reporting of Barrett's esophagus. So what is the meaning of C and M? C is circumferential involvement and M is the extent in length. So you see here, the maximal extent of metaplasia is around 5 centimeters. That's what is thought. It can be even more. However, C means circumferential extent. So when you are measuring circumferentially, how many centimeters in the circumference, that is C, and how many centimeters above in the length, in the extent, is M. So for example, the way you have to describe in your report is C2M5, C2M4, or C1M4, M3. So this is the way you have to describe Barrett's esophagus in your reporting. And identification, I already told you, this is what you do. Now, once you identify that this is Barrett's esophagus, we do high magnification endoscopy, and we also do special narrowband imaging techniques to focus on this island, which is creeping on the squamous epithelium. And in case we find that there is dysplasia or no dysplasia, according to that, we decide when to call these patients for a repeat surveillance. So I will go to the next slide now, just to tell you as to how do we do surveillance in patients of Barrett's esophagus. So this is a classical society guideline from the American Gastroenterological Association, surveillance of non-dysplastic Barrett's esophagus. That means you have found Barrett's esophagus where there is a creeping island on the squamous. However, there is no dysplasia. Even on the image-enhanced endoscopy, neither there is dysplasia on your biopsy. So how do you take a biopsy? 4-quadrant biopsy. So biopsy at 2 centimeter locations. If it is a very tiny island, of course, in 2 or 3 biopsies, you will cover that entire island. Don't go too deep. Now, this is a classic time where you should not use a spiked biopsy forceps. You should use a non-spiked biopsy forceps. Why? Because in case you are going to plan a resection of this Barrett's later on, and if you use a spiked biopsy forceps, you'll create a submucosal fibrosis and you'll not be able to resect it. So how do we do surveillance of a non-dysplastic Barrett's? You see here, quadrantic biopsies every 2 centimeters. And then if you find that there is glandular metaplasia, Barrett's esophagus is confirmed, Then clinical review of patient fitness and preference. This is a very typical thing. Now, maximum length. If the length is less than 3 centimeters of gastric metaplasia, then you do a repeat OGD scopy. You see here, it is not required because this does not require surveillance. However, if you find intestinal metaplasia but non-dysplastic barrettes, then you repeat a gastroscopy 3 to 5 years. You don't have to call the patient earlier. However, if it is more than 3 centimeters in a non-dysplastic barrettes and proven intestinal metaplasia, then you have to call the patient little earlier, every 2 years or 3 years. And every time the patient comes, again do image enhanced endoscopy, again do biopsies, confirm that patient is not having dysplasia. Then we go to the next slide. If you have a patient of dysplasia, now consider this low-grade dysplasia or high-grade dysplasia. Now I want to tell you one more thing here. You know, this pathological identification of low-grade and high-grade dysplasia is not easy. So therefore, you need an expert gastrointestinal pathologist or GI pathologist to be able to identify proper low-grade and high-grade dysplasia. In case you are not sure, you should always take a second opinion. Otherwise, you will unnecessarily subject this patient to a major invasive therapy. Now, if you have a low-grade dysplasia identified, then you should perform a gastroscopy every 6 months until you have 2 consecutive evidences of non-dysplastic barrettes. So you continue the patient on medical treatment, perform gastroscopy every 6 months, and if you find that low-grade dysplasia has gone off and you find non-dysplastic, then again the patient goes back to no surveillance. However, if the patient has high-grade dysplasia, then you have to call the patient earlier, maybe every 3 months or every 6 months. And this is a classic patient which needs to be discussed in a multidisciplinary team as to how we should now treat this patient further and what sort of therapeutic intervention we should offer this patient.
Yeah, I think our patient had a esophageal mass and we have done a biopsy and that has come as a squamous cell carcinoma. So the next question which faces the gastroenterologist is how to proceed. So I think staging comes after that. And now I'll request Dr. Saugata Sen to tell us what are the principles and fundamentals of staging esophageal cancer. A very specific question to him will be that there are a lot of doubts that which is the first modality best suited for imaging this cancer for staging. Should we go straight for a PET CT or CT-MR it will do? Won't PET CT be more cost effective? We'd like to know from you.
Yeah, can I go to the next slide, please? Thank you very much for having me here. So the 7 questions that a radiologist faces in esophageal cancer are such, the 7, we will actually deal with the first 4, which is the focus of this session. I will go through and show you a few images, and the last would be a sum up slide and a short discussion about which to do first, which to do, which not to do, and where all you should use PET CT and where all you should not, and also a little bit about endoscopic ultrasound. Next slide, Dr. Nandi, please. Okay, so this is the first image that I have is of endoscopic ultrasound. So when the patient has been diagnosed with a positive biopsy, the patient has esophageal cancer, endoscopic ultrasound can be very useful. If you see panel B, which is on your right side, all the 5 layers of the esophagus can be expertly visualized on the endoscopic ultrasound. And ultrasound, if it reaches the target organ, is one of the best modalities in any area of the body. So here you can see the mucosa up to the adventitia, the submucosa, the 2 layers of the esophageal muscles very well. If you see the panel A, there's a small thickening of the esophagus, which is probably not involving any of the adjoining organs. So local staging of esophageal cancer, especially in early esophageal cancer, T1A, T1B, T2, these can be best done by endoscopic ultrasound. Next slide, please. So if you see, there are 2 panels here. Panel A shows a very, very small lesion in the lower esophagus, and it is pointed out. But if you see the corresponding endoscopic ultrasound image, it's much well visualized, and the staging is much better on the endoscopic ultrasound. On CT, we might even miss this lesion. But on the endoscopic ultrasound, not only do you pick up the lesion, you can also say that it is probably not involving the adventitia and only the muscle layer is involved. If you see panel B on the right, there again on the top is a CT scan image where the lesion is extremely small. I would have definitely missed it. But on the PET scan, you can see again the image has been picked up. So one of the advantages of using a PET scan. Next slide, please. This is a lesion which is just below the carina on the esophagus. You can see the lesion has got slight indentation of the right mainstem bronchus. And on panel B, a bronchoscopy was performed where you see cobblestoning of the mucosa, which suggests that the bronchial mucosa has been involved. This is of key importance when radiotherapy is being given, because there's always a chance of a fistula with the airway and the esophagus. Next slide. This is again extremely important because local nodal staging, especially when you have not picked up anything on PET scan, is vital to local therapy. So local endoluminal therapy will come later in this session. But if a patient on endoscopic ultrasound shows local nodes, for example, here on panel A, you can see the thickening of the esophagus and also a node which is marked out with the red white arrow. This node was not picked up on the PET scan. You can see the MIP image at panel B. There was no metabolic activity at all in this entire PET scan. So even the lesion and the node were not picked up by PET scan. So here, when the lesion is small and it's got a small node, this is very well picked up on endoscopic ultrasound. It's extremely important. So if there is a node which is there in the local region, a local regional therapy like a submucosal resection probably will not be valuable to the patient. Next slide, please. So the other important virtue of a PET scan is to differentiate between the overall nodal staging, regional versus non-regional nodes. So here you can see on panel B a lesion which is in the lower esophagus, probably involving the GE junction. You can see a node in the mid-thorax, which is a regional node. And again, on the panel A, you can see a node which is below the superior mesenteric artery level, which is non-regional. So anything between the celiac axis below to the lower neck above in the cranial region are within the regional area of nodes. And this is mainly because of the atypical lymphatic drainage of the esophagus, which is more orthogonal to its length. So it goes from cranial to caudal. So any node between the celiac axis and the lower neck happens to be regional, whereas nodes beyond that are non-regional. And on that depends the type of lymphadenectomy that the surgeon will plan. The last slide, please. So this is another PET scan image where you can see definitely a thickening of the esophagus on panel A, but you cannot see the image you cannot see the metastatic disease which is in the cardiac muscle, which is very well picked up on PET scan. So for metastatic disease, a PET scan, which is a whole body scan, so it covers everything, is a mandatory method nowadays, a mandatory protocol, which is used in most centers to evaluate esophageal carcinoma. Please note that esophageal carcinoma many times present late with metastatic disease, and a metastasis has puts the patient into palliative care. Whereas a disease without metastasis, you have many options nowadays. So a PET scan in that way evaluates metastatic disease better than a CT scan. The next slide. The next slide, please. So staging of esophageal cancer it's basically a combination. So for early cancer, endoscopic ultrasound for mild thickening of the disease to stage locally and also nodes is important. For airway involvement, a bronchoscopy is required. And the PET scan actually shows you the disease, mediastinal nodes, as well as metastatic disease. So approach, the next slide would be approach. And the approach to esophageal cancer from a radiology point of view is when a patient is diagnosed with a lesion on endoscope and is proven to be esophageal cancer, we do a PET scan first. And once we have early disease, so there are no nodes in the PET scan, the lesion appears to be small, endoscopic ultrasound is performed. Endoscopic ultrasound can show whether the lesion is amenable for a locoregional therapy or endoluminal therapy, which will be discussed later. If there is airway disease, a bronchoscopy is a good thing to do so that you can you can understand whether the airway is really involved or not, and whether there is a chance of a tracheoesophageal or a bronchoesophageal fistula. And since the disease shares common etiology, so smoking and alcohol, it's good to search for synchronous disease in the upper aerodigestive tract. A thing of great importance is whether it's PET-CT or contrast CT. So if there's a lesion in the lower esophagus, which is signet cell ring carcinoma, which is a variant of adenocarcinoma, the PET scan doesn't work. So they are not FDG avid. So these cases, one needs to do a contrast CT of neck, thorax, and abdomen. Otherwise, we would prefer PET-CT because it's much easier for a radiologist or an implementation physician to spot the disease. And also metastatic disease is easier to pick up on a PET scan. Thank you. I would take any questions if required.
Thank you, Dr. Sen. I think you have brought out very well the role of PET-CT and how advantageous it may be in most of the situations. Two quick questions, one to you and one to Dr. Amit Medeo. Many centers do not have the endoscopic ultrasound EUS facility or good facility, with their expertise. Do you think the management of such cancer really affects in these centers? Like EUS will be so important for you to proceed further? And the question to Dr. Amit Medeo is that in an obstructive lesion where there is stenosis and narrowing, does it hinder your EUS assessment? Suppose you are not able to reach the target lesion. Dr. Sen, please.
Yes. So endoscopic ultrasound, I agree that many centers will not have the disease. So it's like what we prefer is once the disease is proven on endoscopy, we do a PET scan, and if we feel that on the PET scan, on the CT part, especially the disease is very superficial or small, and PET is showing no nodes, and there is a chance of therapy which can be delivered endoluminally. Probably sending the patient for an endoscopic ultrasound to a higher center makes sense. In case you do not have the ability for the endoluminal therapy at all, then probably endoscopic ultrasound wouldn't help much.
Dr. Amit Medeo, please.
Yeah, I think it's a very good question. You know why? Because endoscopic ultrasound scopes are quite thick. And if you have a patient who comes to you with dysphagia and you can't even pass a normal gastroscope properly through it, going with a EUS scope becomes almost impossible. However, in the beginning stages, quite a few years back, if such was the case, what we used to do is we had a 7.5 megahertz wire-guided EUS probe available with us. And by using that probe, we could do excellent locoregional staging of the esophageal cancer. The main impact or the advantage of endo ultrasound is locoregional staging. And they can tell you how much deep is the lesion involving and whether there are any surrounding lymph nodes which are appearing metastatic. So the issue now is, nowadays, we do not have that probe available with us. And most of the EUS centers, now they use a linear scope. They don't tend to use a radial scope. See, passing a radial scope may be also easy, but linear scope, trying to assess a stenotic esophageal cancer is not easy. So I completely agree with you that nowadays, EUS may not be possible in patients who have got stricturous esophageal lesions.
Thank you very much. So we proceed. I have just extended this subtopic and given the staging over here, because this TNM classification as advocated by American Joint Committee on Cancer is followed almost universally. T, N, and M classification, and based on that, we have staging of the esophageal cancer. And this staging further decides our therapeutic strategy. So this is handy to keep these charts with us. Coming to next to Dr. Amit Agarwal, please. Now, we have all heard that there are various modalities to treat esophageal cancer. A very basic question that please give us an overview that which patient is for which mode of therapy. Dr. Amit Agarwal, please.
Yeah, sorry, I was muted. I'm so sorry. Thank you, sir. So I think as largely the gathering is gastroenterologists, so therefore I've kept my slides pretty simple. Can we go to the next slide? Of this very busy slide, the first line is the only thing which matters in this slide. Sorry, I can't answer about endotherapy. You guys are going to answer that. So can I go to the next slide, please? Okay, so now that for a gastroenterologist, you've done an endoscopy and you've got the diagnosis. Actually, you answered the question, what kind of malignancy we're looking at. So if I'm a gastroenterologist, or if I'm standing with a gastroenterologist, what perhaps I'm going to ask the pathologist is, are we looking at a squamous carcinoma or are we looking at adenocarcinoma? Pramesh and Dr. Mohanty sir will possibly talk about treatment strategy for the surgeon. It doesn't really matter. Over a period of time, we have realized that these two malignancies are possibly different. And in fact, GE junction abnormalities and a gastric abnormalities at some point of time will differentiate into two malignancy. I believe so. So as a gastroenterologist, you should ask the pathologist that please don't give me an answer of malignancy. You should daily ask them adenocarcinoma and squamous cell carcinoma, because in future it will be more different than what it is today. The point to be taken at this point of time is that now that we are in the process of staging, please don't stent just now. There is a lot more that we can do to esophageal cancer than stent, although a stent and establishment of feeding remains an integral component of a patient's management strategy, but not now. So if you look at this patient who you have endoscoped, I think you should be looking at few questions in your mind before you start referring the patient to an appropriate person. And in fact, that should be happening in a multidisciplinary meeting, as somebody alluded to, is an excellent tool to answer this question. The question that you should come to your mind, which Dr. Maideo sir has very nicely alluded to, is think of it, where it is, and what kind of it is. So think of it as three possibilities. You have a T1, T2, N0 disease, and we have talked about how do you identify an N0 disease based on CT scans or based on endoscopic ultrasound and problems of doing an endoscopic ultrasound. And then the second thing which should come to your mind is if it is not early stage, then who are the locally advanced stage? You should be thinking in your mind, okay, this guy has got a T3 or a T4 disease, which is very common in our country and has got a lot of node positivity. Unfortunately, a problem of node positivity and tuberculosis has not been alluded to, but I'm sure somewhere it will be talked about. But anyway, said so, if you find your patient has a T3 or a T4 disease, and or a node positive disease, this is a completely different set of patients than the patients which was talked about before. And unfortunately, about half, or as this ISD meet suggested, 40%, a large number of our patients actually present to us with a stage 4 disease. That's our biggest dilemma. Okay. Also think of whether it is an upper one third, lower one third, or a middle third, and also think of GE junction as a separate site. Can I go to the next slide, please, sir? So to give a brief thing, if you have a lucky patient who has got an early stage disease of a T1, T2, N0 disease, surgeon is your go-to man, because it's going to be, obviously there will be a patients who will undergo endoluminal treatment, and I think that's between you and the surgeon to decide whether they're going to go for an esophagectomy of whatever kind, or whether it's going to be endoluminal therapy. But I would only say at this point of time, early stage disease, surgeon is going to be the main treatment. Very few of these patients would require a post-operative treatment if appropriately staged. Second set, next slide. If it is a locally advanced stage, which we decided, most of these patients would undergo a chemoradiation. There was a question in the chat box also, and I think that could be vehemently discussed among oncologists, but a large majority of these patients after chemoradiation will undergo surgery. Very few patients like gastroesophageal carcinoma or upper stomach carcinomas may actually escape radiation, and there's a dilemma about that. So who are you going to involve there? You are going to involve a medical and a radiation oncologist there, because it's a locally advanced disease. Surgery is in picture, but perhaps at a later point of time. If you have a multidisciplinary meeting team in your institute, it is a great idea for gastroenterologists to participate in this, because we need input from everybody, including a pathologist and including a radiologist and all the team members who participate. Largely speaking, upper one third are escaped. They do not get surgery done largely, and they get treated with CT and RT. If somebody asks you, patient, because they come to you for the first time, what will be the gap between a CT RT, that is chemo RT and surgery, you can answer them 6 to 7 weeks is an approximate time between CT RT and surgery. Next slide, please. We will have very small talk on that because there is some discussion later on. Unfortunately, half of our patients are metastatic. Now, that is when the stenting becomes perhaps the most important, because providing alimentation to the patient is a major goal, and the quality of life is major. Here, a stenting or a radiation will come into picture. Feeding, palliation is important, but the mainstay of treatment is systemic, and there is a lot of upcoming role on targeted therapy, and I'll get a chance to talk about that later. Thank you.
I think it has been very well brought out that staging of the disease will decide your therapeutic strategy. So what we propose to do is to first discuss the first two, the most common modalities, that is surgery and chemoradiotherapy, And then we will go on to discuss, as per the stage, what should be our management approach. So coming over to surgery, Dr. C.S. Ramesh, please. Can you just take us through what are the principles of surgery in esophageal cancer, vis-a-vis, how to assess resectability, minimal access versus conventional, and of course, the role that adjuvant therapy plays in surgery these days. It has certainly improved the results of surgery. Dr. Pranay.
Thank you, Bhaskar. So these are important points in considering how to approach non-metastatic disease. So the surgical approach is primarily based on the principle of getting R0 resection. So which approach to take is based on the expertise of the surgeon, what she or he is comfortable with, and what the evidence suggests. And till about a decade back, the predominant controversy used to be whether a transthoracic esophagectomy was better or a transhiatal esophagectomy was better. And we've had a couple of meta-analyses which have looked at this. Considering that the meta-analysis and we automatically associate them with a very high level of evidence, I must say that, can we have the next slide? That the large number of these studies which have been part of the meta-analysis are actually retrospective or prospective studies, and only 4 randomized trials to date which have compared the two procedures. So if you look at the overall complication rates after a transthoracic or a transhiatal esophageectomy, they're more or less similar. I mean, they are increased in one approach with one complication, and it's compensated by an increase in some other complication with the other approach. Next. So if you look at cardiac complications, they are actually 3-fold higher with a transhiatal esophagectomy as compared to a transthoracic esophagectomy. And this gets reversed with pulmonary complications, as you might expect, with a transthoracic esophagectomy being marginally higher than a transhiatal esophagectomy. Next. But what you also need to look at is when you look at all studies, and let me again reiterate that the meta-analysis contributed a large number of retrospective and prospective non-randomized trials, you actually see some bizarre results, which is that anastomotic leaks are higher with a transhiatal esophagectomy, and vocal cord palsy is also higher with a transhiatal esophagectomy. So this brings us to the problem about this meta-analysis itself. So the transthoracic esophagectomy is predominantly an Ivor-Lewis esophagectomy with an anastomosis in the mediastinum, and very few of them had a McEwen procedure which has the anastomosis in the neck. And clearly, these are not similar surgeries. So, but when you lump them all together, you come up with fairly odd results like what you're seeing with this study. Next, when you look at some of the next, please. So when you look at some of the randomized trials, which are, can we get back to the previous slide? So when you go back, next. No, the previous slide, please. Thank you. Yeah. But when you look at the randomized trials, this is where the truth comes out, that in most of the randomized trials, there is virtually no difference between a transthoracic esophagectomy and a transhiatal esophagectomy as far as most of these complications go, which means that the long-held belief that transhiatal esophagectomy has a lower morbidity or a lower complication rate is actually not justified. It's really not true. Next. The largest randomized trial was a Dutch trial which compared a transthoracic esophagectomy with a transhiatal esophagectomy for adenocarcinomas. And this was a mixture of junctional, that is esophagogastric junctional cancers, as well as primary esophageal cancers. And the preliminary report showed a 10% improvement in overall survival with a transthoracic esophagectomy, which did not reach statistical significance because it was an underpowered study. The overall study size, sample size was just 200 and odd patients. Next, a more updated version of the data suggests that there is virtually no difference in 5-year survival. This was a follow-up publication which showed that overall survival was practically the same whether you did a transthoracic or a transhiatal esophagectomy. But next, when they looked at esophageal as compared to junctional cancers, so if you did a subgroup analysis of the esophageal cancers alone, it showed a 14% difference in overall survival with a transthoracic esophagectomy being superior to a transhiatal esophagectomy. And therefore, next, the authors concluded that they would recommend a transthoracic esophagectomy for esophageal cancers, primary esophageal cancers, whereas a transhiatal was good enough for junctional and for cardiac cancers. Next. But these are not the only approaches that we have. Minimally invasive esophagectomy has come into popularity over the last couple of decades, primarily because there have been major technological advances in optics, the equipment that we have, the theoretical advantages of less invasive surgery with really no compromise on radicality, and at least the initial fears of oncological safety, like how radical would your surgery be, the theoretical possibility of port site metastasis, have to a large extent been addressed by fairly well-conducted prospective studies. There are several reports with surrogate oncological variables like an R0 resection rate and lymph nodal yield, which show that a minimally invasive approach is at least as good, if not superior, to an open esophagectomy. Next. So there have been a few meta-analyses which have looked at this. These are some of the immediate complications after or perioperative outcomes after a minimally invasive esophagectomy. Total complications, overall complications seem to be favoring a minimal invasive esophagectomy. Next. So also pulmonary complications alone favors minimal invasive esophagectomy. And next. And overall mortality, perioperative mortality also seems to favor minimal invasive esophagectomy. But we would take this with a pinch of salt because these are all predominantly prospective non-randomized trials, which brings us to one of two randomized trials which evaluated a minimal invasive approach with an open esophagectomy, which was again done by the Dutch group. And what the time trial showed was next, that the immediate perioperative outcomes with the primary endpoint was pulmonary infection in hospital was 1/3 in minimal invasive esophagectomy as compared to an open esophagectomy. So clearly showing that at least as far as pulmonary complications were concerned, a thoracolaparoscopic approach was superior to an open approach. Next. So oncological outcomes, we don't expect major differences, but we also need to be sure that we are not compromising on radicality. So reassuringly, the time trial showed that both disease-free survival as well as overall survival were similar in the two groups. Next. But all this is randomized evidence. So what happens in the real world? We have a couple of very good examples which come out of Japan and the Netherlands, which show that when it comes in the real world, outside the restricted confines of expert centers in conducting randomized trials, there's virtually no difference between an open esophagectomy and a minimal invasive esophagectomy, except in very marginal differences with atelectasis. Most people would consider that a 5.1% versus a 3.6% difference in atelectasis or prolonged ventilation of just under 2% difference would not actually be clinically significant, though they are statistically significant. And the only differences that were clinically as well as statistically significant were operative time and blood loss. Perioperative mortality, pneumonia, all of them were fairly similar between an open esophagectomy and a minimal invasive esophagectomy. But again, this is because this was all centers put together, admittedly in a very regulated structure like what they have in Japan, where even every minimal invasive surgeon is actually accredited before they're allowed to do minimal invasive esophagectomy. Next. Similarly, with other complications, again, there was virtually no difference between the two approaches, again coming to show that when you extrapolated the results of randomized trials to the real world, these differences or the superiority of minimal invasive esophagectomy actually disappeared. Next, these were similar to another study which came out of the Dutch esophageal cancer group, which again showed that though their randomized trial showed superiority of minimal invasive esophagectomy, when it came out into the real world, practically every complication, whether it was pulmonary, anastomotic leaks, rectal paresis, mortality, was no different between the two groups. Interestingly, and this is can go back to the previous slide. Interestingly, what was seen was that the gastric conduit necrosis was actually higher in the minimal invasive esophagectomy group, and this has been consistent across most studies. We don't really know the reason why, whether it is the increasing use of NOG devices close to the gastric wall, but this has been something which is consistent across a number of studies. Next, so to me, I would leave with these take-home messages. Minimal invasive esophagectomy is the ideal approach for operable esophageal cancer. It does have reduced morbidity with equivalent oncological outcomes. However, with the caveat that it needs to be done in experienced centers, and when it goes out into the community, the difference between, or the superiority of MIE actually goes away. Next, I'll go to this last question. Okay, so I think that's
to you, Dr. Pramesh. Right. And do you think, in your opinion, that minimally invasive surgery is restricted by availability of expertise in our country, or it is done widely in most of the centers?
So I wouldn't actually say there's a restricted availability, because thanks to laparoscopy, most minimal invasive procedures have been performed quite universally across several cities and geographic regions. And just converting from a laparoscopic approach to doing a similar procedure in the thorax is actually not a very big transition, and I don't think that by itself is a restricting factor.
Thank you.
Said that, I would still reiterate that it needs to be done in centers with high volumes, with surgeons with high volumes, and not by the average general surgeon.
Thank you. The next modality is chemoradiotherapy, and I invite Dr. B.K. Mohanty to give us in a nutshell about the principles of chemoradiotherapy in esophageal cancer, an overview. Dr. Mohanty, sir.
Good afternoon, Dr. Nandi, Dr. Govind, Dr. Saraswat, and to all the participants. Broadly speaking, the principles of combining the chemoradiotherapy started not long ago. In fact, the cancer biology of the squamous cell carcinoma and adenocarcinoma, since the mid-1990s, over the last 20-25 years, for most solid tumors, whether it's head and neck, lung, cervix, GI malignancies, have shown that when we combine the chemoradiotherapy in an appropriate setting for the appropriate stage, the synergistic tumor cell kill is improved. That is number one. The other part that we need to know is, besides the principle, I think we have to see the other slide, Dr. Nandi, first. The other slide is, I have two slides. Yeah, okay. Now, the principles are broadly for two. One is for esophagus. Normally, we call it disease cure. Is a remote possibility. We call it as disease control. And then the other one is for palliation. And usually the type of treatment, the aim that we define is definitive, where we combine the chemotherapy with radiotherapy. And we have realized over the last 20 years that the combination of chemotherapy plus radiotherapy is superior to chemotherapy or radiotherapy, plus minus ER in a suitable stage of the patient. Usually it is an alternative for T1 and T2, early stage, and for the operable stage 2 and 3, it is for those group of patients who take it as a choice other than surgery, and also for the medically inoperable patients. These are the two groups where we consider the definitive radiotherapy. More importantly, all my gastroenterology colleagues should know where they should send the patients for neoadjuvant chemoradiotherapy. We have now realized that for operable stage 2-3 and for borderline inoperable patients in the good general condition, the neoadjuvant chemoradiotherapy is superior to neoadjuvant chemotherapy or perichemotherapy. Of course, it is superior for squamous cell carcinoma more than for adenocarcinoma. And what we have also realized over these last 20 years of incremental studies are that definitely compared to the primary surgery, when we do the neoadjuvant chemoradiotherapy, the downstaging of the disease, the pathologic response of the specimen show a longevity in the disease control and survival. More importantly, that we all should know, as Dr. Amit, I would say that before you do the stenting, after you have done the endoscopy and you are seeing a circumferential structure, try to send the patient to a multidisciplinary team or to an oncologist, the person might tell you that which are the patients which might benefit with the palliation before we do a stenting, or we combine the stenting with radiotherapy or chemotherapy. The palliative chemoradiotherapy with good general condition definitely improves the disease-free survival. And the ideal course of palliation is usually a short course that we do between 2 to 4 weeks' time. Although you might be concerned about the TEF, the tracheoesophageal fistula or stricture, what I can emphasize here for you to take home is that for a short course of palliation with radiotherapy or chemoradiotherapy for the suitable patient to improve the disease, dysphagia-free survival, that should not be your concern. Next slide. Can I have the other slide? The one you had shown. No, the one you had shown in the beginning. Okay. What should be the dose of radiotherapy? What you can appreciate is that the dose of radiotherapy earlier used to be something like 50 gray. But now, from the real world of the National Cancer Database of US of about 8,000 odd patients, the left part of the slide, you can see that the neoadjuvant chemoradiotherapy is superior to radiotherapy, and a dose of 41.4 gray over 3 weeks is as good as the 50 gray over 5 weeks. Of course, the chemotherapy regimen, the gold standard is our cisplatin 5-FU. The other regimen which we are considering these days are the triple drug regimen, which is considered superior for patients who are in good physical status. Thank you very much.
Thank you, sir.
Nandi.
Thank you. Thank you very much. And we'll come back to you, sir, later on this. We have discussed diagnosis, we have discussed staging, we have discussed in principle the various modalities of therapy. Now we get on to how to treat, our management approach to esophageal cancer. What we have done is we have divided into early and advanced but resectable, and finally metastatic or unresectable cancers. My only request to the panelists now will be, I think we'll have to speeden up our process a bit. And with keeping that in mind, we straight away go to management of early esophageal cancer, stage 0 to 1, the role of endotherapy. And the next question will be again back to Dr. Mohanty sir on early esophageal cancer treatment, but let's say stage T1B, which has invaded the mucosa. So over to you, Dr. Amit Medeo, management of early esophageal cancer, endotherapy role in intramucosal cancers.
Can you go to my next slide? Okay, I'll just very quickly pass through. First of all, the diagnosis of early esophageal cancer should be done on a white light endoscopy, because we have got various types of image-enhanced endoscopy like narrowband imaging and various other modalities. But you should first identify the abnormal area. And after identification, then we have to start knowing what type of early cancer it is. So next slide. So what we do is on narrowband imaging, what we have to study are these capillary loops, which are seen on high magnification endoscopy, high resolution endoscopy, and also NBI. So on NBI, what happens is, because we are using only a blue and green light, the red is cut off, this vasculature in the mucosa and the submucosa becomes evident. Now, by studying the vasculature, you can make out whether there is a high-grade dysplasia and whether there is an early cancer. So this is what is called as IPCL. IPCL means the type of loops, intraepithelial, papillary, capillary loop pattern. So if you see these types of loops, depending upon the type of loop that you see on high magnification, you can come to know whether this looks like an early cancer. For example, this slide is showing you a typical M1, that is superficial mucosal cancer. See, M1 and M2, what is superficial mucosa means? M1 is involving the lamina propria. M2 is muscularis mucosa. But as when it comes to SM means submucosa. So M3 is muscularis, is going into the submucosa and deeper. Now, depending upon this pattern, if we feel that this looks like an early esophageal cancer, then what we do is we subject these patients to resection. Now, resection by EMR or ESD is not done only for therapy. It is also done for diagnosis. So if you are suspecting an early esophageal cancer, we do a resection, provided, of course, your resection is going to be safe. If by doing a ESD or a EMR, you are going to create a perforation, then you should not do a resection for diagnosis. However, if you are expert at doing EMR and ESD, you can even perform a ESD of an early, so-called early cancer for diagnosis. And after removing the tumor in end block, you send it for histopathology. On histopathology, if it shows deeper invasion, the patient should be referred for further therapy, preferably a surgery, a curative surgery. But if you find R0 resection on your ESD or EMR, then you have already seen that this is early cancer on image enhanced endoscopy. This patient will have a very high chance of cure. So next slide, please. So what do we mean by this early cancer? Look at this. M1 over here and M2, M3. Maximum limit is M1, 2, 3. As soon as it goes to SM1, that is submucosa, the chances of lymph node metastasis keeps on increasing. I'll just show you one more slide. Next slide, please.
This is the
One more slide. One slide ahead. Now just look at this. M1, M2, M3. Even at M3, you can see lymph node metastasis 8%, 4%, 4%, 18%. But when M1, M2, there's hardly any chances of lymph node metastasis. So if at all you want to do any EMR or ESD, your tumor has to be either M1 or M2. Maximum invasion has to be lamina propria or at the most muscularis mucosa. Anything beyond it, you are going to land in trouble. So M1, M2, M3. Next.
For this distinction, EUS is a must?
No, with EUS, you can't make this out. This is done only on image enhanced endoscopy. See, because on EUS, these subtle changes you can't pick up, whether it is involving the muscularis mucosa and the lamina propria.
Okay.
Yeah, next slide, please. So this is how we perform the ESD. ESD is done by marking the lesion, the body, whatever is looking abnormal, and then by dissecting out and by remaining as close to the circular muscle fibers of the esophagus. And anything above the circular muscle fibers, from the submucosal space, the entire specimen is taken out en bloc. Okay, so identification, demarcation, marking, and resection. So next, please. And this is our difference between EMR and ESD. In EMR, what we do, we just put some fluid cushion in the submucosa, lift that tumor, and then use a snare and take it out. But for ESD, the snare is not going to catch that whole tumor. And if you try to remove that tumor piecemeal, you will create a recurrence and you will do an inadequate resection. So if the tumors are more than 1.5 or 2 centimeters, you should never do a EMR. You should only do ESD. And in ESD, what we do is we make a fluid cushion in the submucosa and go below in the submucosa and dissect out this whole tumor en bloc from below, and circumferentially the entire tumor is taken out en bloc, not in a piecemeal fashion. So next slide, please. Very quick meta-analysis. What to do? EMR or ESD for early lesions? Meta-analysis of 21 studies. You see here, EMR is advocated only for lesions less than 2 centimeters and ESD for anything more than 2 centimeters. What is the pool data? R0 resection rate is somewhere around 90% if you have selected the patient properly. But if the tumor is more than 2.5 centimeters in circumference or large, R0 resection rate sometimes drops to 85%. And 5-year recurrence rate you see here with EMR is only 23% and ESD 2.9%. And 5-year recurrence rate in squamous cell cancers is 32%. Adenocarcinoma is quite low, 4.2. Next slide, please. So what do we advise for early esophageal cancer? Endoscopic resection or surgery? To tell you the truth, there is no randomized controlled trial on this topic. There has been only some retrospective data on comparatives. And these two data are there. One is from National Cancer Institute Surveillance, Epidemiology and Research. That's the SEER study. Now see here, 742 patients for T1S and T1 lesions. There is no difference in cancer-specific mortality. However, this is not extrapolated in later data. For example, in the National Cancer Database, the NCDB database, almost 4,000 patients. In T1A, 68% patients, T1B, 32%, all are intramucosal cancers. For T1A, where it was restricted only to the lamina propria, there is no difference between endoscopic resection and surgical resection. But as soon as it goes, even in the muscularis mucosa, better survival with surgery. So therefore, even though theoretically speaking, we can remove tumors involving the submucosa by endoscopic submucosal dissection, today it is considered that if you have on your specimen involvement of submucosa, this patient should go ahead with a proper surgical resection rather than only stopping at the endoscopic resection. So presently, EMR or ESD is only restricted to very, very superficial early squamous cancers or early superficial adenocarcinomas in the lower end of the esophagus. Barrett's is even worse. First, if you find a cancer in Barrett's, after endoscopic resection, there is a very high rate of recurrence as well as metachronous lesions, 22%. So be very, very careful when you are doing resecting endoscopically a cancer in a Barrett's esophagus. Thank you.
Thank you, sir. I think you have brought out very nicely the distinction where to use surgery and where endotherapy in intramucosal cancers. We just go to the next stage, T1B, where it has invaded through the mucosa. Dr. Mohanty, please, do you think it is just a definitive chemoradiotherapy, or we should do a multimodal approach for this?
Can I have the slide and can I take off from Dr. Maydev? And I must say that what he said is also true for T1B. And to inject a little bit of humor, it is to each his own. People do it the way they feel comfortable in their institution. And although it was said by Cicero somewhere around 2000 years back, that holds true for early esophageal cancer. We see it for less than about 15% of the patients, and maybe in our country it would be still less than 10% of the patients. I do not know, and the group might discuss how many have got the good experience or the rate of practice for endoscopic resection in our country, the group can say. The competing practice will be that the gold standard is esophagectomy, or at present stage, it should be minimally invasive esophagectomy. The endoscopic resection combined with chemoradiotherapy for this group of patients has also emerged as an esophagus sparing approach. Thank you.
Thank you, sir. And I think we come to the largest group of our patients who present to us, basically management of locally advanced resectable cancer. We'll request Dr. Pramesh and followed by Dr. Amit Agarwal comments on this. What do you recommend for this large subgroup of patients? Advanced but resectable cancer, stage 2 and 3. Dr. Pramesh, please. Sir, you have to unmute yourself.
Yeah. So can I have the next slide? Yeah. So one thing that has come across very clearly is that for T1, 2, N0 disease, primary surgery is probably the best way to go. But provided that the T1, 2, as well as the N0 has been clearly established by an endoscopic ultrasound. So this is practically the only situation in a low volume disease on a CT or a PET CT that we actually perform an endoscopic ultrasound in current practice. Next, the other set of patients, which is the vast majority, which is either T3 and above, T3, T4, and any node positive, one thing that is very, very clear is that some form of neoadjuvant therapy is indicated. Next. So there are a lot of studies which have been done, and I think some of our previous panelists also alluded to this. One of the most famous being the CROSS trial, where they looked at neoadjuvant chemoradiation followed by surgery and clearly demonstrated an improved survival with neoadjuvant chemoradiation. But I'll just add some caveats to this. We've gone far too carried away by this one single trial to change practice. And next, what we actually need to look at is the large number of other trials which have looked at neoadjuvant chemotherapy. There are more than 10 trials each on neoadjuvant chemotherapy and neoadjuvant chemoradiation. And there's also been a few meta-analyses which have looked at that. Next. And what these meta-analyses show is that neoadjuvant chemotherapy alone followed by surgery improves survival compared to surgery alone. So let's get this clear. As compared to surgery alone, neoadjuvant chemotherapy is superior. Next. Similarly, the more than 10 trials which have looked at neoadjuvant chemoradiotherapy also show that chemoradiotherapy before surgery is better than surgery alone. Unfortunately, what we don't have is clear data on direct comparisons between neoadjuvant chemotherapy and chemoradiotherapy, very few of those trials. And we've extrapolated the results, the margin of benefit with the neoadjuvant chemoradiation trials with cross-trial comparisons with neoadjuvant chemotherapy, which is completely unaccepted in routine, if you had to look at evidence-based medicine, and considered that chemoradiation is superior to chemotherapy. I'll show why this is a myth based on some other studies that have been done. Next. So what we clearly show is that when we come to direct comparisons of neoadjuvant chemotherapy and chemoradiation, though there is a trend, and I must emphasize this is a mixed bag, there is a trend towards a superior outcome with chemoradiation. This is not a clear benefit that we are seeing over chemotherapy alone. Next. But what we also need to look at is the perioperative mortality. Most high volume centers claim that perioperative mortality after neoadjuvant chemoradiation is similar to what it would be with surgery alone. But let's look at the actual randomized trials which have looked at this. They clearly demonstrate that perioperative mortality is higher with chemoradiation followed by surgery compared to surgery alone. And this is in distinction with the chemotherapy alone trials, which show virtually no difference in perioperative mortality. Next. So this also came about in a subsequent meta-analysis. But let's quickly look at examples of more recent trials. The MRC OEO5 trial, which randomized patients to either less chemotherapy to more chemotherapy, which means that they were randomized to either 2 cycles of cisplatin-5-FU versus 4 cycles of ECX, showed very similar R0 resection rates, postoperative complications, increased toxicity with more chemotherapy, but most importantly, very similar 3-year survival. So clearly showing that more chemotherapy is not better than less chemotherapy, and we need to come to some kind of an optimum level at which chemotherapy needs to be given. Next, we also have the FLOT4 trial, which looks at FLOT versus MAGIC. And this is very important, especially when adenocarcinomas are concerned. MAGIC has long been the standard of care. And when you compare FLOT to MAGIC, you actually see marked differences in progression-free survival as well as overall survival favoring the FLOT regime. So at least as of now, for adenocarcinomas, as far as chemotherapy alone is concerned, FLOT should be the standard of care and not MAGIC. Next. So we also have, so this is where I come to the randomized evidence comparing neoadjuvant chemotherapy to chemoradiation. These are all adenocarcinomas. And when you look at the complete response rates, we have much better complete response rates with chemoradiation compared to chemotherapy alone. R0 resections also higher. But when you look at the 3-year survival, the curves are practically on top of each other, which means that there is no difference whether you give chemotherapy alone or chemoradiation prior to surgery. And for adenocarcinomas, the logic of giving chemoradiation prior to surgery is very, very flimsy. Next. And this is another, so when this is the subset analysis, clearly showing that in adenocarcinomas, there is no benefit and a marginal non-statistically significant benefit with squamous cancers as far as chemoradiation is concerned prior to surgery. Next. So the take-home messages as far as we are concerned is that neoadjuvant therapy is the standard of care for most esophageal cancers, that is all T3 and above, all node-positive tumors. The debate on whether neoadjuvant chemoradiotherapy or chemotherapy is superior will continue. We don't have level 1 evidence to support one over the other. The meta-analysis of chemoradiation versus chemotherapy showed no difference. We need to understand that we need to treat squamous and adenocarcinomas as 2 different diseases. Let us not fool ourselves into thinking that they are in the same organ, so they have the same disease. They behave very differently. Their etiology is very different. The prognosis is very different. If you had to ask me for my gut feeling, this is not based on evidence. I think that neoadjuvant chemoradiation will be superior to chemotherapy in squamous cancers, but we lack the evidence currently to support that. And at least with adenocarcinomas, there's virtually no data to support that chemoradiation would be superior to perioperative chemotherapy with the FLOT regime. There are a couple of trials which are currently ongoing, which are comparing FLOT or MAGIC versus neoadjuvant chemoradiation. I doubt in adenocarcinomas that they will actually show a benefit. And I'll stop with this.
Thank you very much. Thank you. And I actually hate to interrupt this way, but I think we really have to move up a little bit fast, even faster now. So we are left with 2 important questions. One is management of unresectable cancer, and the other is, of course, palliation. Can we just go ahead, Dr. Amit, to the next question?
Yeah, sure.
Yeah, so we come to you, management of locally advanced.
I think it's largely answered by Ramesh, so I think we can skip it.
Yeah.
Well,
So
we
management
have
of
time.
unacceptable
Yeah, correct. Sorry. Go ahead. Sorry, go ahead. Acha, okay, we
No,
go
it's
to
for
the
you.
possible or metastatic
Yeah.
carcinoma. Next slide, please. We finish it faster. Okay. So we've gone to a stage when the curative intent is all gone. So this is the question which is coming up in chat boxes, which I saw. I think this is one area where the stentors, gastroenterologists, and radiation oncologists will fight on the issue, which is fine. We just want a patient who is eating fine. There was also some issue about jejunectomy in a neoadjuvant setting. I hope discussion would answer it. The question which was raised was CTRT for palliation. I would not go for it, but I did see that Dr. Mohanty had talked about CTRT for palliation. Possibly I missed the communication, but no, we don't combine two modalities for palliation, either radiation followed by chemo if required or stenting followed by chemo, as the case may be. Suffice to say for gastroenterologists, because we're largely talking about stage 4 disease, it is going to be systemic therapy, and the golden standard at this point of time is chemotherapy. Next slide. For the gastroenterologist, when they should look smart and they should ask the patient, do you have a HER2 new report? Do you have an MSI report? You know about MSI because you talk a lot about Lynch syndrome and colonic carcinoma. MSI is there in all solid tumors. So ask the patient, do you have a HER2 new and adenocarcinoma? Do you have got an MSI done? A PDL1 is programmed death ligand inhibitor. For a medical oncologist, oncology is a completely different field. We don't talk about chemotherapy these days. We talk about all these jargons, scientific jargons, and a next generation sequencing. So a lot is being done in this tumor and the other tumor. Next slide, please. And we have the drugs for the HER2, for the vascular factor called ramucirumab, and the latest kid in the block, which is immunotherapy, which excites your immune system to attack their cancer cells and treat them. Very exciting future. I think this must be the last one. Thank you.
A quick word from Dr. Pramesh, let's say without slides, surveillance protocol at your center after the initial definitive therapy, whatever modality it is.
Right. So this is the area where we have the least data on and the least evidence on, and I'm not going to stick my neck out with any definite recommendations for this because we just don't have the data to support this. Conventionally, what we do is to follow them up 4 monthly for the first 2 years and 6 monthly for the next 3 years. We don't perform any kind of imaging or testing unless there are symptoms, and this is primarily based on the fact that once you've had a recurrence in a potentially curative esophageal cancer, the salvage options are not great. I mean, regardless of the advances that we've had with chemotherapy and radiation, the only possible potentially curable situation is if you have a isolated local or a regional recurrence without any systemic metastasis. And primarily because of this, it doesn't seem to be cost effective to intensively investigate patients who are asymptomatic. So we restrict investigations like a CT or a PET CT or an endoscopy only for patients who have symptoms. But having said that, this was not based on any strong data. We just don't have the data to support whether intensive follow-up is superior to non-intensive follow-up.
Yeah, thank you. I think it would be nice to exchange this with other centers also, like what do they do? And we are just coming over to our last two questions. Palliation, Dr. Amit Meddev.
Yes, when we talk about palliation endoscopically, I just have one slide, and I'm just going to show you these type of stents. See, because when patients, I'll tell you something what has changed. 30 years back, when patients used to be referred, 75% of the patients who came to the for treatment were deemed as inoperable, incurable, and they used to be sent for stenting. Now that percentage has come to 50%. Probably because that remaining percentage now is treated effectively because of the surgeons expanding their horizon. Now they are resecting a little bit more advanced tumors. And second is advancement in chemoradiation. Now, therefore, stenting patients have gone down a bit, 50% of what it was before. Now, the best part is the stents now, a variety of stents available to us. Because of these stents, we can virtually stent a tumor which is causing obstruction anywhere in the esophagus, except if it is too close to the cricopharyngeal junction. If it is too close to the cricopharyngeal sphincter, then placing a stent becomes difficult because that compresses the trachea. And the patient has a constant foreign body sensation. We had an issue of stenting gastroesophageal junction tumors, OGJ junction tumors, because of reflux. But now we have anti-reflux stents like this. So if you place anti-reflux stents, the patient does not aspirate even after placement of stents. Nowadays, the stents are knitted design. They are not laser cut, because of which the stents go according to the tortuosity of the esophageal stricture, and it doesn't cause too much of pain. So expandable stenting, according to me, if once you have decided to palliate dysphagia, is one of the most useful techniques for improving the quality of life of the patient. Because this procedure can be done even without admission to the hospital. The procedure time is hardly 15 minutes. The patient starts swallowing food right from the next day, and whatever life the patient has, that quality of life is much better. That's all that I want to say. If there are any questions on stenting, I will answer. We can go to the question answer session.
We can go
Yes.
take it up at the discussion time.
Yes.
And we come to the final slide. Dr. Mohanty, please. Overall survival in esophageal cancer. Has it changed over the years?
Okay. Can I have the slide, please? Yeah. I think I would say not because I'm speaking, but all the gastroenterologists should keep this slide in their endoscopy room. This is the esophagus is the sixth largest or leading cancer mortality. Broadly, the factors are dependent on age of diagnosis, subsite of the esophagus or gastroesophageal junction, squamous cell versus adenocarcinoma, the performance status of the patient, and whether in your institution after the diagnosis you have the multidisciplinary treatment approaches available or not. Broadly speaking, when we see the SEER data, about 40,000 patients for localized disease, it's about 50%, and it can increase to about 70 to 90% for T1 and T2 disease. For regional, it drops down to 25% with a median survival of 24 to 30 months. For metastatic disease or inoperable patients, the median survival is between 6 to 12 months. And overall, what we see now is the 5-year survival is around 20%. That is the global scenario that you have to always keep in mind. On the right side, when you compare the adenocarcinoma, which is increasing in the West, that is the lower part of the graph, you will see that it is slightly superior than the squamous cell carcinoma as of now. Thank you all.
Thank you, sir. I think in the last 1 hour, we have been successful to bring out what all is there between initial diagnosis and our final stenting. And suffice to say that, yes, it's a multidisciplinary approach that is required. And the specifics of each modality of therapy, how do we approach for staging our approach to therapy for the various stages of the cancer, I think it is there in the presentation for anybody to refer. It will be kept in the library. And having said this, these are the just last few slides based on our algorithm-based, our diagnosis, what do we do for early esophageal cancer, locally advanced, and what we have for unresectable esophageal cancers. Thank you very much, and I'll hand over to Dr. Saraswat and Dr. Govind for the summing up.
Well, I think I must thank the panelists and Dr. Dr. Bhaskar Nandi for doing a brilliant job of providing detailed information in a very lucid and a clear manner about all the aspects of esophageal cancer. We do have questions, but I think we're now close to 1:30. And Dr. Amit Agarwal, Dr. Pramesh, and Dr. Sogato Sen have been busy answering the questions on the chat box. So a few questions, important questions from the endoscopy point of view have come in. And Dr. Mahadev will take the liberty of sending these questions on to you. So if you could please respond, and we can then answer them, send them back to the questioners, or post them on our website for their information.
Can you stop sharing your screen?
Sorry, Govind?
Can you stop sharing your screen? Yeah, perfect.
Yeah, right. So I think these questions are certainly going to be intriguing and answering, but I think we are now going to eat into people's lunchtime if we go on with our discussion, because those questions are going to evoke detailed discussion. So I think um, I'll take a couple of minutes to thank all of you for all the effort put in. Dr. Nandi, Dr. Amit, I think your slides and presentation was excellent. Dr. Pramesh, very detailed data. Professor Mohanty told us all about the SEER and the national data. And I think the imaging modalities and the importance of PET CT, I think now people will really have this stick in their mind that PET CT we cannot do without it. And Dr. Amit Agarwal, I think the last bit that you told us about all those new drugs that are in the pipeline and that are coming up is what has a lot of people excited about the future of oncology. So all this was very useful information, and I thank you very much for the effort you have put into this panel discussion. Dr. Govind?
Thank you so very much for a wonderful panel discussion on carcinoma esophagus. I would say that again, this is a dream panel which we can have for on this topic. All experts, those who understand the disease biology very much. So it has been truly a very very educative session of master class, and I hope that all the audience will get benefit out of it. Anyway, we are going to put this panel discussion on the library of ISG for future viewing. This panel discussion will also be available on YouTube, ISG page of YouTube, and also in the Facebook for long time. Again, I mean, just to reiterate one more point, that whenever we see a patient coming to dysphagia, while doing endoscopy, after taking biopsy, first plan that what is the further course of action we are going to take in a given patient, and then act. Just don't act and the plan later will be a wrong strategy. Like doing a biopsy and putting a stent and then thinking, oh, what do we do now? That may not be the most appropriate way to treat. And this is what all the panelists has emphasized time and again, that you first see a patient, take biopsy, as Dr. Amit Mayode said, that what kind of biopsy you should take, and then after that till you wait for report, plan that what test are going to do, stage the disease, and then act upon what is best for the patient. With this, again, we won't take much of time. We need to thank each one of the panelists and the moderator. It has been a wonderful exposition of carcinoma esophagus. Before we end, let me invite all the viewers for the next masterclass. That's the next Sunday, 12 to 1. That's October 4. And this will be on the carcinoma stomach, again, one of the important diseases which we see. And this will be moderated by Dr. K.M. Mohandas. And we will have, again, expert panel to discuss different aspects of treatment of carcinoma pancreas. And again, to remind that we have already invited for applications for ISC elections for 2020. So we look forward for your nomination or applications for ISC elections. With this, thank you, everyone. Thank you, Dineshji, for the technical support. We never see you, but again, your work is superb. Thank you, Lupin, for supporting the master classes. And with this, we see you next week and have a great day ahead. Bye-bye. Bye. Thank you so very much.
Thank you.
Thank you.